Hello and welcome to episode 11 of VetPhysioLife. I'm Shane Jasani and I'm joined as always by Kim Sheader. Hi Kim.
Hello.
How's your long weekend going so far?
I'm having a wonderful time so far. Thank you very much. Yeah, all good.
Fantastic. Great to hear. And thanks for making the time on the Saturday afternoon of a long weekend to have a call.
My pleasure. No problem.
So Kim, today I thought we would talk about a topic that I know that you're a big fan of, and that's the whole area of physiotherapy in the context of respiratory, so breathing-related problems, and cardiac or heart-related problems. Before we do, though, I thought it might help if you could just explain, just kind of briefly, we talk a lot about physiotherapy. What essentially is physiotherapy trying to achieve in general terms, if it's possible to generalize?
Oh, as an overarching thing, that's quite a big thing. I think the official definition is something along the lines of aiding return to function through exercise and manual techniques. It's sort of along those, and education, it's sort of along those lines. So regardless of what system we're trying to affect, whether it's the musculoskeletal system, which is the muscles and bones and joints, which is the most obvious thing when you think of physio, or whether it's the neurological system, which is nerves and the brain and the spinal cord, or whether it's the respiratory system, which tends to be called the cardiorespiratory system, so therefore it's the heart and the lungs in together, or any other system. We're trying to allow that individual to restore as normal function as is physically possible with the body they have.
Yeah, that's cool, because I think as you sort of said, most people when they think of physio do think of muscles and ligaments and bones and stuff like that. But I thought it might be, that sort of definition that you've provided or description that you've provided, hopefully is a good way for people to understand that although those are the most common areas, they're not the only areas that can be helped,
absolutely.
Right?
Yeah, absolutely. There's lots of other stuff that can be affected and can be helped by physio, and is really interesting for us as physios to get involved with. So yeah, definitely.
Fantastic. So I thought before we talk about non-human patients, I thought it might be nice for the listeners to hear a little bit about your experience in human healthcare and ICU and so on, in the context of human patients that had problems with their breathing or their heart or related places. Yeah.
Absolutely. So when I qualified, I started working in an NHS hospital where we did 4 monthly rotations, and you do that through all the different areas in the hospital that have physiotherapy. So in conjunction with what I was saying about the definition, we worked on the medical wards, on the surgical wards, in paediatrics, in intensive care, as well as outpatients and, stroke unit and all sorts of different places. I very quickly just realised that I actually really quite liked working on intensive care and with the respiratory patients. So I then chose to specialise in that area. And then of my 10-year NHS career, I pretty much spent the majority of 8 years doing very specific cardiorespiratory physiotherapy, which in and of itself has quite a spectrum, I have to say. It can go anywhere from, so it can be exercise related. There's a lot of respiratory physio that doesn't actually, it's focused more on general cardiovascular fitness, because if you're not physically fit, then you're going to get short of breath quicker, your heart's not going to be as an effective pump as it should be, and so that's a really important part. So this is where cardiac rehab and pulmonary rehab come in, and I spent a fair while working directly on a cardiac rehab unit, doing lots of that. But then also, and really my true love is phlegm, because I'm weird. But anyway, there we go. So I really liked working on intensive care. So that was working with usually ventilated patients, not always ventilated, but the majority of them were. So having a machine breathing for them. And you have two remits as a physio, when you're working with ventilated patients. One is to try and prevent them getting pneumonias and chest infections, because we know that there's quite a significant increase in the risk of you getting a chest infection when you suddenly start shoving tubes down places where they shouldn't be. And unfortunately, that's what you have to do. You have to put a breathing tube down into the windpipe to allow the ventilators to work. So one of the things we did was trying to prevent them from getting chest infections by keeping their chest as clear as possible of the natural secretions that every single one of us makes every single day. Whereas you and I, we cough and we clear our throats without even realising we're necessarily doing anything. Obviously people that are ventilated are also paralysed and sedated very heavily, so they can't clear their own secretions. So that was what physio did for them. And then obviously the other big thing, which was probably more the majority of our caseload, was to treat the people that already had chest infections for whatever reason. So some of those were just, a lot of those would be sort of infective exacerbations of COPD, which is a big posh fancy way of saying bronchitis and emphysema and smoking related diseases usually, and then getting a chest infection on top of their already poor lung ability, and then they needed help to be supported and help to clear all the stuff off. It could be asthmatics that had got a chest infection on top of their asthma, and then that just tipped them over and they couldn't cope anymore. Or it could just be the slightly more vulnerable populations that have just got a nasty chest infection that's developed into pneumonia, and they needed some support until they were recovering. There was a wide and wonderful, far more things than that, but they're probably the main majority, and that gives them a good idea of what I did, I guess.
Yeah, fantastic. And what about as far as the heart's concerned? Were you involved with sort of patients that had heart failure?
Yes. So I did quite a lot with, as I said, I worked for 6 to 8 months. I was the lead of a cardiac rehab unit. So you would go, you'd be involved with the acute patient care when they first came in, either after having had a heart attack or having an exacerbation of their heart failure. So CCF is what it can be called in humans sometimes. So if that gets worse, they'll get a lot more breathless, a lot less able to move and get around and about. So you'd see them both on the wards where they were acutely medically unwell, give them some low-grade exercises and things that you wanted them to do to help start them get back on their feet, etc. And then would then progress to home programs and then get them back in once they've been discharged home to do cardiac rehab, because there's a lot of really quite nice evidence that shows that cardiac rehab and exercise in human patients with heart failure can actually be more effective in some cases than the drugs that are given to support them. Now, that's not to say that I'm telling people that have cardiac failure or anyone else, any other animal that has cardiac failure, that they need to get rid of their drugs, because that's not remotely what I mean. But if you think about it, if you know exercise is effective, then why shouldn't we be using it in conjunction with the drugs? Because then maybe we can possibly, certainly improve quality of life, definitely. There's lots of studies to prove that. And even possibly in conjunction with working closely with the doctors, might be able to reduce the amount of drugs needed, which is always beneficial, because at some point in time, they're likely to need to have more medication. So if we can keep them on as low a dose as possible for as long as possible, then in my head that has to be a good thing.
Yeah, definitely. And Kim, so often with heart conditions, what we say is that the heart's failing, whether it's because of a muscle problem or a valve problem or both. And a lot of the medications that we prescribe to patients that have failing hearts are not actually fixing the heart itself, but they're trying to manage the consequences of the heart failing.
Yeah.
In essence. So does physiotherapy, does that do a similar thing? So do you say it tries to manage the consequences of the failing heart? Or do you think it actually helps the heart muscle itself to get stronger or get healthier? Or?
No, I think it actually helps the heart muscle itself to get stronger. And it will have other training effects as well. But, despite some of the problems with cardiac problems being that the certain bits of the heart are working too much and they get too sick and can't work very well, the other bits of the heart tend to become weak. Certainly the theoretical supposition that cardiac rehab is based on is that you are exercising the muscle of the heart to allow it to become a more efficient pump than it has been previously with cardiac failure. Now, that's not to say that we're going to fix it, because we're not. We know that. That's, if there's failure there has to be failure there. But it can improve. It's also going to have a knock-on effect with things like, so when I said there's secondary effects, it's also going to have effect with things like you start breathing more deeply for a period of exercise. You're going to strengthen your diaphragm, which is a big muscle that helps you breathe in and out and take deep breaths. If you can breathe air in and oxygen in more efficiently, then that's going to oxygenate your blood quicker and better. So that's going to reduce your sensations of breathlessness. If you increase your strength in your arms and your legs by exercising and helping those muscles get stronger, you're going to have a couple of things. First of all, the muscles in your legs will, if they're stronger, they can help get the blood back into the heart from your legs a little bit more effectively, potentially. And more relevantly, the stronger you are, the easier it is to move, as I'm sure everyone at some point in time that has trained for anything will know and realise. So by conditioning the whole body, I think physio and cardiac rehabilitation and pulmonary rehabilitation are specifically targeting the primary effect, which is why it works well in conjunction with the drugs that, as you say, look at some of the secondary effects.
Yeah, fantastic. So that's all about humans, isn't it? It's got nothing to do with animals, right? Like
no,
animals don't benefit from this stuff.
Well, no, that's not true at all.
I'm just staring at you.
You're leading me down the garden path there. No, the problem is we don't have any research as far as the animals are concerned. But if you look at how cardiac failure works in dogs and animals, there's a lot of similarities to the physiology and how it works in humans. So, yeah, it's an area that has not been looked at within dogs purely and simply because animal physio hasn't been around for that long, and so we're still getting everyone to get to grips with the idea of physio for musculoskeletal problems and neurological problems, and cardiac problems haven't really had a chance to be looked at and investigated. But obviously, because respiratory in the human world is my little thing, it's something that I really want to have a look at. And as and when the opportunity arises, which hopefully will be very soon, I'd love to do some research just to see if cardiac rehab for dogs with heart failure can be beneficial, because I'm sure it could be. But we need to have some actual robust data to prove that and put that into effect, basically.
Yeah, because I know that, some of what you were describing, I have a little bit of experience of from working in a veterinary ICU when we have had dogs in particular with breathing problems and the odd one on a ventilator. And so some of those things you described, but I'm pretty sure that there's a lot more that could be done than what we were doing. And I think we both agree really that although there may not be evidence at this stage, as far as we can tell, there's no good rhyme or reason why all of those things that are beneficial in people won't also be beneficial in dogs and indeed cats, although cats are obviously their own uniqueness. But
absolutely, yes, they are. Yeah, no, I don't see why there isn't any reason whatsoever. And when I worked in an animal specialist centre in the past, we didn't have any ventilated, long-term ventilated animals, but I certainly helped successfully in conjunction with working with mainly the anaesthetists and the medics as well, dogs with pneumonias. I had a fabulous dog that was a pup, 7 months old pup that had a tracheal, so a windpipe narrowing stenosis, and had unfortunately managed to get himself a nasty chest infection. We think from just being a very enthusiastic puppy and ate incorrectly and inhaled more than he actually swallowed, bless him. But I managed to do, because he was young and we knew that he didn't have some of the other potential reasons for aspiration that you get in dogs, which can be problems to do with closing off the larynx, and also a thing called a Megaoesophagus, so where the stomach, the food pipe is too big, so the food just kind of sits rather than actually going down into the stomach. So with those, you need to be careful of tipping them in, putting the dog in the wrong position, because they might end up just aspirating more or inhaling more than they previously had done. But because we knew he didn't have those risks, I was able to do postural drainage with him. So basically that just meant positioning him in manners that had his head down and his bum up in the air and his lungs, his lungs in a position where if I could mobilise the phlegm, I could get it to drain. And it was, the nurses and vets were all pretty grossed out, I have to say, but after 10-15 minutes of me treating him, he had green snot running out of his nose like no tomorrow, and I was very excited about the whole thing.
And what kind of puppy was he?
He was a bulldog, English bulldog. Yeah.
Bless him. Very cool.
Yeah, bless him. But he got better and he went home, and he was a very, very poorly dog that they all thought wasn't going to be going home. So I kind of ticked that one off to physio, help that one a bit, definitely. And
so let's say he was a bigger dog, an adult dog. I mean, what would you do if you were trying to do this to a dog that was like 60 kilos or something?
You get really big wedges and lots of pillows, and you build stuff. You find a handyman or woman that can build you a wedge, basically, like a little ramp kind of thing, so you can then position them up, down, wherever you want them. Yeah.
And what do they do in people? They have beds that you can slant up and down, or
Yes. So in people, we use the electric beds, but the electric beds that the normal beds you see in a hospital, what a lot of people don't realise is that you can lie them completely flat, but then tip the feet up, so they've got their heads down, and their feet up in the air, and we treat them like that and that for a little while before we put them back up in a nice upright position. So, and all sorts of weird and wonderful equipment. However, equally, old-fashioned pillows did always end up being used as well with humans. So,
yeah, fair enough. All right, cool. Kim, it's been fantastic. I look forward to us being able to explore all of this around real patients in the future.
Absolutely, me
too. But for now, I'm sure we'll talk about it from time to time. I mean, I think I've said to you before, it certainly makes a lot of sense to me. Yeah. So I'm keen to see it put in practice, because I'm pretty sure the benefits far outweigh the risks. But it's all as you said, non-evidence based at the moment. But great
absolutely.
Stuff. All right, fantastic. Enjoy the rest of your weekend, and we will catch up again next week. Yeah.
Thank you. You too. Yes.
Cool. Thanks, Kim. Cheers.
All right. Bye.
Okay. Bye-bye.